So phage therapy has gained lately a lot of traction. It's been known for many years, but it really, in the last few years, has become like a new tool to combat multi-drug resistant organisms. And with this therapy, there are also very important challenges that have not really been properly addressed at the biggest scale. We often read about successes on isolated cases, but rarely we discuss failures, or very rarely failures are actually published in reputed journals. Well, AAC just published a series of cases of failures of phage therapy. But the interesting part of this paper is that the authors did a wonderful job trying to characterize the reasons for these failures, which I think are very important to understand the complexities of this approach and moving forward with this triad of tools. So we have the author, the main author of this paper here to talk about her research. Welcome to Editors in Conversation. The objectives of this podcast is to discuss the phage therapy as an approach for multi-drug resistant bacteria, understand a little bit more the challenges of phage therapies, and elaborate on the specific issues that can influence the success of this therapy. This episode, as usual, is brought to you by the Antimicrobial Agents and Chemotherapy Journal, available at asm.org/AAC. I'm your host, Cesar Arias, editor-in-chief of AAC, and this podcast is supported by the American Society for Microbiology that publishes AAC. If you plan to publish in AAC, ASN members get up to 50% off on publishing fees. So visit asm.org/membership to sign up if you are not a member, and you should be. Don't forget to check our latest issues of AAC with wonderful papers, like some of them forthcoming for talking about this topic, but also mechanism of resistance, pharmacology of antimicrobial agents, epidemiology, and clinical therapeutics, among others. We have also really nice collections there that you can browse on particularly on new section of antimicrobial stewardship. So to discuss this case, I have a very distinguished guest who is also a friend of mine, which is very nice. Is Dr. Saima Aslam, who is the director of the Solid Organ Transplant Infectious Disease Service at the University of California, San Diego, and is professor of medicine at the University of California in San Diego, and is the main author, the corresponding author of the paper I just mentioned. Welcome to the program, Saima.
Thank you very much. It's a pleasure to be here.
So let's start from the basics. I think we have a few years and we have several podcasts in phage therapy. So I think everyone is now familiar with phage therapy. So, and you have been one of the pioneers of these therapies in UCSD. So after all these years, where are we with phage therapy? What is your, big picture evaluation? Are we any better?
Well, we're better in some ways and definitely trying to get better in others. I will say, so I treated my first patient with phage in 2017. And, we've treated a number here at UCSD and involved in others around the US and other countries. At this time, based on some of these podcasts and talks and papers that have been published, there's really a lot of interest in phage therapy. And the issue now is that the demand and interest really outpaces the availability of phage. And so at UCSD, for example, we've now had, more than 2,000 requests by patients or by physicians reaching out for their patients. And, a number of them, I think, may benefit from phage, but unfortunately, only about 15% or so actually end up getting phage therapy. And I think part of the issue is, yes, there's a lot of interest, in particular when we see these published cases of, wonderful outcomes, which is great, but everyone wants that for their patients, right? But the issue is that there aren't that many groups that have phage. There aren't that many large-scale phage libraries, so that if I have an isolate today, I can find phage for it tomorrow. That whole process currently is really taking months. And so, some patients, their infection resolved. For others, they passed away. And so in the end, a very small amount of people end up getting phage. But yes, the interest is
So
there for sure.
yeah, definitely. I've been one of the most probably skeptical voices on this because I understand the complexities of this approach. And, and, there's been a lot of hype, and sometimes in medicine, this hype sometimes is not at the same pace of the research of the evidence. Um, so I want to congratulate you for being brave and publish negative outcomes on patients, which is very rare on doing this, right? So, so why don't you tell us a little bit before we go into the weeds of the paper and the details? Because one of the things that I think about when I think about phage therapy, unfortunately, we have sort of infrastructure potentially here in Houston to do this. What are the main challenges when people think about phage therapy? Because a lot of people think, as a lot of interest, as you mentioned, that this is like a magic bullet. And I don't think that is. So, what are the challenges that you need to think when you decide, okay, we're going to get for this kind of approach?
Okay, well, first of all, skepticism is healthy. So I appreciate that. I think that helps us, understand sort of scientifically what we're trying to do when we give people phage therapy. So in terms of challenges, I mean, there's a number. They're just initially just logistical challenges. So I've talked to a number of physicians who reach out, and their expectation of phage is, I have a patient today in the ICU. Can we get it next week? So there are a lot of logistical challenges of starting off with, I'm interested in this for my patient, to the patient actually getting it. And none of those logistical challenges, I think, make it into the papers because we kind of show you the end product. So sort of what I mentioned earlier, we really need very large scale phage libraries. So phages tend to be highly specific for the organisms that they're infecting. So because I have a Pseudomonas phage doesn't mean it's going to get, all different Pseudomonas isolates. And so that sort of big step is needed to have these massive collations of phages. So that's sort of one step where a number of times, we strike out and you don't find phage for your patient's isolate. The other thing right now, this is all very ad hoc. So again, I think people seem to think there's this really well done network of you want phage for a patient and we find it and it's manufactured and we get it. But right now, most of the phages that are being used to treat patients on these individual bases are coming from individual kind of academic laboratories. And so these laboratories are not funded as a clinical phage manufacturing facility. And so that's part of the delay. And, some labs can only take care of a few patients a year. And so again, that demand is
Saima,
there, but the
sorry to
infrastructure
interrupt.
isn't. Go
Yeah,
ahead.
sorry to interrupt, but because I just want you to emphasize about the logistics, right?
Okay.
Knowing how bacteria respond, we know that the ability to become resistant to these phages is one of the main problems that we're going to discuss. And the ability to re-evolve these phages requires a very important infrastructure that I don't think is easy to find in academic or even private or clinical settings. Can you emphasize a little bit about the logistical problem for phage therapy?
Yeah, I just want to make sure I'm understanding you. So you're worried more in terms of when we use phage and develop resistance, how are we going to overcome that? Is that your question? Yeah.
Yes, yeah.
So
Once you get the phage, let's say a phage that is supposed to work in vitro, you deploy it. You need a system to follow that and to understand that the target organism may not have become resistant to the phage in very short period of time, which is something that happens regularly in these approaches.
right. So I think so several I guess caveats there. So phage resistance doesn't always uniformly happen in the patients that we're treating. Certainly, there are certain phages, so Pseudomonas phages in particular, in real time, I've seen development of bacterial resistance to the phage that we're using to treat a patient. On the other hand, when we look at Staph aureus phages, at least in clinical cases, that's almost never been described. So it may not be as common as we think it is, but I think it may be pertinent, to certain phage and bacteria combinations rather than as a whole. So, but yes, so currently, unlike antibiotics and bacteria, when you have a positive culture, you get your susceptibility results, usually 24, 48 hours later. Now we have a number of these genetic tests, so you can get it within hours. With phages, that currently does not exist. There are a number of different ways of checking susceptibility, and right now there's no consensus. So unlike, again, antibiotics, where we have a consensus approach and, CLSI guidelines, for phage therapy, some centers check susceptibility by means of what's called a plaque assay, meaning, you have a bacterial lawn on an agar plate and you basically put in different dilutions of phage looking for plaques. Other groups will do sort of a time kill assay. So one, we don't even know which of these is better than the other in terms of, calling something susceptible and using it like that in a patient. So that's sort of, I think, sort of step one or hurdle one right there. And there's no standardization. So with keeping these in mind, when I have a patient and in vitro, we started off with a number of plaques and a great time kill assay. And now the patient is still bacteremic or developed bacteremia on phage, and I want to look for resistance. That process could again take a couple of weeks, actually. So it's rare to have that resistance information in real time to make real-time changes. We did do that for one of our patients in this case series, but real time there also meant, it took us at least a week to make that change. So yeah, I mean, I think that's a logistical issue, but it kind of goes. I think it's up to us as the phage community to actually develop some consensus guidelines. First of all, to describe what is susceptible. Each group has its own definition of what that is, and so
Correct.
without that, it's hard to figure out when it's resistant, basically.
Okay. So Greg, beautiful response and very clear. Thank you very much. So let's get into your cases. So you report a series of patients that have these, for the people in the audience who is not familiar with this, called left ventricular assist devices, which are basically a foreign body that try to help your heart while you wait for a heart transplant. And of course, this is a foreign body that when it gets infected is incredibly difficult to treat, because the only way to really treat that is to remove that. And you can't remove that because obviously the patient is not going to be able to survive without it. And although there are certain case reports in the literature about this, you report these patients, all of them failed therapy. So tell us about the process and how you gathered your data and how you did for these patients.
Okay, yes. So, as you mentioned, LVADs or left ventricular assist devices tend to get infected actually frequently. So up to a third will get infected. And generally, they end up being on lifelong antibiotics or antibiotics, till they get their transplant. And so one of the hardest in this situations are the Pseudomonas aeruginosa LVAD infections. And these unfortunately are not popular. These are common is the right word. And, we get emails about these patients. And so I feel like in a setting where we have no real antibiotic answer, there's a lot of interest in using phage. And so the 5 cases that I described in this paper is a collation of efforts. So 2 of these patients were treated by my colleagues, Dr. Ran Nirpaz and Ronan Hazan in Israel and Jerusalem. And then the other 3 cases were treated at UCSD. So one patient actually got treated twice with 2 separate courses of phage therapy. So yes, I mean, these patients receive, so these cases are over time. The first one here was 2017. The most recent one was 2023. And how we approach these patients has changed a little bit over time. So with the first patient that I treated was our case 1 that we thought would be, a magical response. Unfortunately, the patient did not respond to therapy. And I think from that one is we started understanding that maybe we should be getting serum samples and, checking for resistance and checking for other factors that relate to a not successful outcome. Um, I think one key is, the patients all tolerated phage well, but 4 of these 5 patients actually developed bacteremia while on phage therapy. So all 5 patients had already a history of recurrent bacteremias with Pseudomonas or persistent bacteremia, but they were all had negative blood cultures at the time we actually started phage. But then 4 of them developed bacteremia while on it. 2 were within the first week of treatment. So I think, it's something to be concerned about and not be blasé in terms of phage is very safe. It is, but I think in this setting, these cardiac devices tend to be infected for years and months, and they have large biofilm burden. So I think at least, for the 2 patients that developed bacteremia within a week, probably is related to sort of massive biofilm destruction. I don't know that, but that's a hypothesis based on the clinical reaction, because the bacteria we got when they had breakthrough bacteremia were actually susceptible to the phage that they were getting. So resistance was not the problem there.
Okay, so let's analyze. I mean, the beauty of this paper is you analyze the different factors for failure. So one of the factors that you mentioned there is the diverse susceptibility of the phage to the different strains. And when you think about a strain that infects a patient, you always have to think about there may be subpopulations that may respond, another subpopulation that may not. And particularly when you have in this biofilm state, that's going to be even more difficult. So let's talk about that, how you identify this maybe subpopulation or heterogeneity in response.
Right. So I think, so again, for these LVAD infections, they're infected for a long period of time, have had, a variety of antibiotic pressures over time. And so for the patients that we have, before we treated them with phage, we try to get all these different isolates with varying antibiotic susceptibility profiles, whether it's from the driveline or from their blood. So for 2 of our cases, we actually had very detailed analyses in terms of we had multiple samples before phage therapy, during and after. And for that patient, we did see 3 different clades of Pseudomonas aeruginosa sort of present at baseline. We saw that the phages that we used to treat the patient were not uniformly active against all these different clades of infection or clades of bacteria that we had at baseline. So that may have played a role in why the patient did not do well. But for the others, we didn't have that detailed of an analysis or that number of isolates to test. I mean, there were 2 patients in which sort of the pre-phage and the post-phage Pseudomonas isolates were actually identical on sequencing. So I think it would be different in each patient, but certainly at least in one, we saw, a great diversity at baseline of Pseudomonas isolates, as well as susceptibility to phage.
So a lot of people talk about these phage cocktails and all that. So can you clarify how many phages you use? Do you use cocktails? How many do you use? And how do you deal with this problem?
Okay, yes. So one of the ideas of using these phage cocktails or combinations is to sort of try to get ahead of the development of resistance gain. So get phages that act at different areas or attach to the bacteria at different attachment sites to prevent them becoming resistant. So of these 5 cases, 2 actually used a single lytic phage. It was not a cocktail. But 3 cases received a combination of anywhere from 2 to 4 phages. And we understand and realized that even though the patients had a cocktail of phages, not each phage in that cocktail was, equally active against the Pseudomonas isolates. So yes, so here we have both approaches. We had, 2 patients that got single lytic phage, they failed, but then we had 3 that got combinations and they also failed. So, I think in these patients, there's no one thing that led to failure, and it's probably different etiology in each of them.
So, and just to clarify the audience, you use antibiotics at the same time that you use the phages, or you
Yes, so
use the
in these
phages
settings,
alone?
yes. So in these settings, because these patients were all actively infected, and antibiotics would be standard of care, so we continued antibiotics and added on phage therapy to that. For two of the patients, we actually did in vitro testing prior to phage treatment, looking for antibiotic and phage synergy. And so two patients actually received a combination of phage plus antibiotics that in vitro was synergistic.
Okay, so this is the other thing that I was going to ask you about. How do you? I mean, I know there are not a standardized methodology to do these synergistic tests, and this is something that is really important to try to give the clinician some idea. So, how do you develop this testing, and how is it done in other parts of the country or the world?
So there are different ways, and again, sort of different ways of testing susceptibility. So also different ways of trying to assess for synergy. For the two cases that I mentioned here, they were both tested at Dr. Hassan's lab in Jerusalem. And so what he does are actually time kill assays. So time kill assays, with bacteria alone, with antibiotic alone, and combination and phage alone. And within that time kill assay, you can see a difference when the combination is used. And I think we have figures of that within the paper that sort of show that difference. Other groups have developed sort of a 96 well plate kind of assay in which you get something similar to a heat map in terms of a calorimetric assay, in which you can assess, decreasing or changing combinations of phage on one side and changing combinations of antibiotic on the other side of that 96 well plate. So these are the two common ones that I've seen that's been used.
So, how do you feel when you get a result with this test? Do you believe in that synergism? Are you just try because that, or even if the result is not favorable, you continue the antibiotics?
So I think one of the reasons for doing the testing is really assessing for antagonism. And I think so that I would believe in more. I don't want to use a combination of antibiotic or phage, or for that matter, even just, two or three phages. We want to make sure they're not antagonistic. If they're synergistic, I think that's great. But that hasn't been a focus in terms of antibiotic choice. I mean, sometimes part of the issue is also, what's tolerated by the patient as well. I will say one case that was published, that was Chip Schooley's case. In that case, they actually did show that using a synergistic combination with phage and minocycline against Acinetobacter baumannii actually did lead to a patient response. Because in vitro, the patient's isolate was resistant to minocycline and resistant to phage, but when used together, it was actually synergistic, and clinically, that combination helped. So probably, again, there's a lot of variability here. But yes, the synergy I'm not as, I guess, obsessed by as, making sure there's lack of antagonism.
Okay. Beautifully said. Okay, the other factor that I think is fascinating that you mentioned is this neutralization of the phage by the host, right? And I remember you presented this data a year ago, I guess, in Houston in one of the conferences, and publishing this. And I think people are becoming more aware of this situation. So tell us about this, and how do you measure this? How do you predict this to happen? Is something that you need to do in routine? So how do you handle that phenomenon?
So when we first started treating patients with phage, 5, 6 years ago, we certainly weren't looking at it. But I think in particular, when we started seeing a few failures is when I started assessing for serum neutralization. And now, I think most people would do it routinely. So what happens is, phages are viruses, and similar to other viruses, a number of them will elicit an antibody response. And again, this is not true for all phages. We've looked at sort of different kinds of phages in people and seen that some elicit a strong reaction and others have, no serum neutralization. But it is something I'm seeing in most of the patients that I treat, including transplant recipients, usually about week 2 of therapy. And so what we started doing now is getting serum samples prior to phage at baseline and then weekly. And usually for some patients, I have it out to like 3 months or 4 months to assess for that response. Most people have done sort of crude in vitro assays looking for just serum neutralization, so phage and patient serum, being neutralized. But we are actually, we have a series of 9 patients, and we're actually, I mean, it's sort of an experiment in process. I don't have results, but we're looking at them not just for the serum neutralization, but actually looking at antibody responses, so IgG, IgM, as well as a variety of cytokine responses to see what's really happening, kind of at a molecular level rather than the gross sort of output that we see as serum neutralization. But yes, I think it's something we need to test. I don't think we know currently if that truly is what's related to failure. There has been a case published in which a patient doing well on phage, when he clinically deteriorated, it was also seen at the onset of serum neutralization. But I've treated patients that had neutralization that did great. So I think it's an unknown. We know it happens, so we should test for it. What I'm trying to do with the experiment I mentioned earlier with these 9 patients is to see if any of these outcomes, whether the cytokine or antibody outcomes, are related to clinical outcomes. I think as a whole, we don't know that yet. And again, some
So
phages don't elicit that response.
I see. So how rapid do people develop these neutralization antibodies? Have you have an idea, or they are preformed before even you give the phage? Are there any studies that show any of that?
Yes, so a number of cases and case series, including some that we published in AAC, do show onset of serum neutralization generally around the 10 to 14 day mark. So what I've done now actually is treat patients for lesser duration of time and still get good outcomes. So I'm not sure long durations are needed, but yes, we'll see neutralization around 10 to 14 days. I've had one patient that had baseline 100% serum neutralization to a Staph aureus phage, but she had received sort of similar phage, many months ago. So there is some concern, and there is ongoing, as we do trials, we'll be testing to see if development of neutralization precludes repeat, phage therapy in the future. We don't know that answer yet. But that I think is something for sure we'll be testing.
Is there any way to prevent this eliciting these antibodies?
Not that I know of. As I said, I've treated immunosuppressed patients, and they all developed a response as well. So, no, I think, there certainly are some phages, again, that don't elicit much of a response. So perhaps, those would be preferred for a bacterial type infection. But actually, so I'm going to back up. So yes, I don't know how we would impact the patient in terms of preventing neutralization. But on the phage side, there definitely is work, sort of genetically modifying phages such that they, will have certain protein moieties or others on their capsules to prevent or reduce the neutralization development on the patient side. So yes, there's work on the phage side to try and prevent that or reduce that.
So this is fascinating, and I mean, going back to this phage susceptibility of different subpopulations, you mentioned before that there are ways to try to assess susceptibility in vitro, but when you have this diversity, how do you tease out this subpopulation? Are there anything people are doing anything in vitro that help us understand that process better and how to tackle it?
So I think for patients that have large biofilm burden, sort of like the cases that we described, the key really is trying to collect as many isolates as you can over time. There are some sort of studies, or I guess preliminary work being done in terms of assessing kind of sort of shotgun sequencing the microbiome in instances where recurrent UTIs, for example, tend to come from the E. coli we have in our gut. So trying to understand what the patient has prior, prior to treating with phage, not necessarily the bacteria from the urine, but their gut microbiome in general, and then using that as, sort of a marker of choosing phage therapy to treat that patient. But that would be just really preliminary at this time. But I don't know of other ways to try and come around that.
Okay. So after all this expertise, what have you learned with these failures? What can you tell people with these failures? Are you more optimistic, less optimistic? What did you learn from these patients?
So I do want to clarify that of the patients that we've treated at UCSD with phage, we have an 83% success rate of successful outcomes with phage therapy. That being said, those are for different indications. So my take home, at least from this paper, currently, I don't think we know enough of how to successfully treat endovascular Pseudomonas sort of biofilm infections. I think there's a lot that should be done, but perhaps we can do that in other clinical syndromes that we do have success. So when I talked about an 83% success rate with phage therapy, that's been in the setting of recurrent UTIs, recurrent bacteremias, and prosthetic joint infections and pneumonias. But for the LVAD, so, a device with endovascular infection with this organism, I'm not really sure what else we can do other than learn sort of all the steps that I mentioned and do it in a systematic manner.
So,
Go ahead.
of those success stories, I know we are talking about failures, but I want to balance this conversation. What would you say is the most treatable organism with phage at this point, after all this experience that you have accumulated?
So I think it's not specifically just the organism, but also the clinical syndrome. So
Okay.
what I'm really interested in, I'm sort of getting funding to work on are recurrent urinary tract infections with E. coli and Klebsiella. There have been a number of successful outcomes, from our center as well as many others that have been published. Also with Staph aureus infections for bone and joint, there's been, I think, great successful outcomes. Pseudomonas, to me, seems equivocal. There are certainly some situations where we've seen really good outcomes. But in the setting of chronic lung disease, where we, have generally seen most Pseudomonas, I feel that the success potentially may be short-lived. I think the other thing we need to understand is perhaps not use phage only as an antibiotic, but trying to erase the Pseudomonas, for example, in CF. But to understand its impact on its microbiome in general, and the pulmonary function test, and sort of looking at, I think, other outcomes that are not necessarily always microbiologic. And as an example for that, I want to talk about this one case. This was E. coli recurrent prostatitis, in which we treated with phage. The patient had recurrent episodes literally every 3 to 4 weeks and was on, weeks and months of IV meropenem or ertapenem. We treated that patient with phage, targeting, this E. coli. After phage, she hasn't had more than, after 3 of these patients, actually, they've been more than a year out from phage therapy without symptomatic UTIs. Some of them have had the organism again. So the prostatitis patient, surveillance cultures in 6 weeks shows E. coli. But when they're sequenced, the pre and post, the post-phage E. coli has a number of virulence factors that are now missing. So if we just looked at culture, we would see a failure because he had E. coli before and he has E. coli now. But I think there are nuances there that we don't see with antibiotics. But clinically, you're out with 0 UTIs and living, IV antibiotic free is a big deal and, a great outcome. So I think we need to understand these things a little bit more too, in terms of, what truly should we be looking at in outcomes for clinical trials.
Yeah. So I want to close with your crystal ball of the future, and I'm worried a little bit about trials that include all comers, because as you mentioned, there's going to be such variability with different clinical syndromes that we may lose the patients where this is very, very important. I mean, this UTI, particularly now that we're seeing so much ESBL, E. coli producing community acquired recurrent UTIs, which with organisms that are resistant to oral drugs, patients end up having to go out to IV antibiotics and they recur and recur. This is a syndrome that I think seems low hanging fruit for a clinical trial and very specific and very targeted. So, how do you see the future and the design of these clinical trials for this phage therapy?
So I will say I have received, or almost about to receive, NIH funding to do such a trial in recurrent UTIs and kidney transplant patients. But certainly there are a couple of companies as well with E. coli phages that will be initiating trials, and one company has already looking at recurrent UTIs. So I think, yes, so in terms of a crystal ball, I think as we do these compassionate use cases and learn from them, both from failure and success, we understand more of which clinical syndromes perhaps are best suited for some of these early phase clinical trials, to try and get a win, basically. I think if you have a win in a clinical trial, it opens up doors for more research and perhaps, more fine-tuning of phage for other clinical issues, for example, the Pseudomonas LVAD sort of clinical scenario. But yes, I think there's a lot to be done. For antibiotics, we're multiple decades in. For phage, we're at least clinical phage therapy. We're within, the first 5 to 7 years. But I think we've learned a lot, but certainly have, a long way to go. But there's a lot of interest now, from government funders as well. Funding not necessarily a company, but academic groups to do research in phage, clinical research in phage therapy.
Well, beautiful conversation. Again, congratulations on this paper and again being brave to teach us when there are failures, with the caveat that you mentioned that there are successes, and this is a evolving field that is needed due to the crisis of antimicrobial resistance that we're having, and I think there is a lot much to learn. So thank you very much, everybody. Thank you, Saima, for coming. This is Cesar Arias, editor-in-chief of AAC, signing off.